All right, Vision, I think we can start with introductions.
Okay.
Fantastic.
Okay, so we will begin. Thank you so much, everyone, for joining us today for our 10th session for PEDS Picks for Practice. And PEDS Picks for Practice is basically an educational initiative aimed at empowering those who care for children. And so today's 10th session is on reflections on the radiology of intussusception and pneumoperitoneum in children. So for our 10th session today, we have Dr. Chuks Agi, who is a professor of radiology and a faculty of clinical science in University of Port Harcourt, Nigeria. And so we welcome him and thank him so much for his time and for his dedication and willingness to provide us knowledge today. He is also a consultant radiologist with the University of Port Harcourt Teaching Hospital in Nigeria and the director of Sports Institute of the University of Port Harcourt, Nigeria. And so thank you all for joining us today. Please make sure if you have not already registered, please use this QR code to register. And so you could use this QR code or the link below. And also after the session, there's an optional anonymous feedback survey that only takes about 5 minutes. So please, if you have time, complete that to help us figure out how we can improve in the future. And also just a reminder, the materials presented in this lecture series is for educational use only and is the property of the presenter, which today is Dr. Agi, and is not for further dissemination beyond the intended educational program. Therefore, for any PDFs of slides or lecture recordings, feel free to reference them yourselves, but please do not share. If you registered, you will have a follow-up email with the information. And if others are interested in the content of these lectures, please encourage them to sign up as attendees. Thank you so much. And if you have any questions, please email PEDS Picks for Practice. And if you have registered, you have access to our YouTube channel, which has the recordings of previous sessions. Without further ado, I will give it access to Dr. Agi to share his screen. And thank you so much, Dr. Agi, again for your time today.
Vision, do you want to stop sharing so Dr. Agi can share?
Oh, yes, that's important. Okay.
Dr. Agi, we can't hear you yet.
Hear me?
Yes.
So I can go on.
Yes, sir.
Well, thank you so much for inviting me to be part of this program. You know, we all need to, improve ourselves, remind ourselves of the need to, get better as we attend to our patients, especially the little ones, that will take, over in the future. Today, we are looking at two topics, the radiology of pneumoperitoneum and the radiology of intussusception. These are two conditions that occur quite regularly in children. And without much ado, I will start with, the radiology of pneumoperitoneum. It is said that my people will perish for what? Lack of knowledge. And that is why we want to ensure that we are up to our game we are, up there with all the knowledge that is requisite for us to give the best attention, to those who are ill, those who are unwell, those who have any form of disease or the other. So we seeking knowledge is the right thing for us to do. Today we'll be looking at the outline, looking at our discussion this afternoon or evening, wherever you are, looking at these outlines, defining what the disease condition is, having a brief introduction, looking at the anatomy of the GI, the etiology and the clinical features, imaging modalities, radiologic diagnostic algorithm that is very important to know what we will do first, and then we'll summarize and conclude, and then take questions as the need arises. Pneumoperitoneum is described as extraluminal gas within the peritoneal cavity. The term refers to the presence of air within the peritoneal cavity or abdominal cavity, but outside the hollow viscous where it should be. When, majority of pneumoperitoneum occurs from hollow viscous perforation. So this accounts for 80 to 90% of incidences of pneumoperitoneum. It can be fatal if it is left undiagnosed and therefore untreated. There are two types. We can classify them based on their etiology into, an idiopathic or primary pneumoperitoneum, and then the secondary pneumoperitoneum that is due to the ruptured viscous. And then we can also classify them into that which will require surgical intervention and that which, would not require surgical intervention, or we can say it is a benign pneumoperitoneum. Of course, the surgical pneumoperitoneum is that which results from perforated hollow viscous, while the non-surgical one might be related to maybe a postpartum process. It might be related to, thoracic causes. It can be related to, post-surgery, and various other benign causes. The presence of pneumoperitoneum does not, however, always imply a perforation, based on the fact that sometimes, like we said, it can be, just mechanically ventilating someone can lead to, pneumothorax, pneumomediastinum, and then pneumoperitoneum. So, it is not always an implication that, an intra-abdominal disaster has happened. Likewise, not every bowel perforation results in pneumoperitoneum, because some of them seal up so quickly and release very little gas or fluid into the peritoneal cavity. Now, we can sub-classify them based on their locations. So we can have restricted extraluminal gas, which will be if there is an abscess formation with gas-forming organism inside the abdominal cavity. It will produce gas, but that has not resulted from perforated viscous. And then we have the intraluminal gas, which is also intraperitoneal, but is normal within the bowel loops with peristalsis occurring. We can have the abnormal gas in, a lumen, like the biliary tree, when we have gas within the biliary tree. We can have gas inside, a solid organ, due to infection. So we can have intraparenchymal gas seen in liver abscesses. Also, when tumors, undergo chemoembolization, when, during treatment, they can also give rise to gas within them. And then we have intramural gas, which will be secondary to ischemia. The GI, we won't go much into it. We all know already, that in the abdomen, we're looking at the distal esophagus, the stomach, the small and the large bowel. And then they have their vessels, the celiac trunk, the superior mesenteric and inferior mesenteric arteries, supplying blood, using, through the vascular arcade, within the mesentery. And then we'll have the venous drainage that will go to the portal vein. Now, the wall of the GI on the, basically would have, the mucosa, the submucosa, the muscle, which can be circular or longitudinal, and then we'll have a covering serosa. So when there is a defect in this layer, then air, fluid content can get into the peritoneal cavity and then give us a disease condition. This is a diagram telling us the peritoneal reflections that we see. We have the parietal peritoneum, we have the visceral peritoneum, and then that invests the various organs within the abdomen, and then it gives rise to various species, the greater sac, the lesser sac, the paracolic gutters. These are the areas where air and liquids or fluid can actually accumulate. So the most common cause of pneumoperitoneum is disruption of this wall of the hollow viscous. Now, the various etiologies would be, we can have barotrauma, thoracic, mechanical trauma, perforation, NG tubes can do that. When we do endoscopies, it can also cause perforation. Foreign bodies can. Sometimes we can, peptic ulcer or, can rupture, or can perforate and then give you, collection of fluid and air. Ischemic bowel diseases, bowel obstruction, neck, appendicitis, diverticulitis can all. And then sometimes post-peritoneal dialysis, we can also have these collections. So it typically presents in terms of clinical presentations. It will present with signs and symptoms of peritonitis, and then on free air within the, when we do our imaging. So it requires, for 5 to 15% of cases, non-surgical treatment may be necessary, especially when it is not that of ruptured hollow viscous. But perforated viscous account for 85 to 95% of the pneumoperitoneum cases. And that obviously will require intervention. Therefore, we can, in quotes, if our suspicion is that there is, pneumoperitoneum, we can, look at it and, be on the very careful side to exclude perforated viscous before we say it is non-surgical. So the complaints will be abdominal pain, might be abdominal tenderness, might be rebound tenderness, guarding, abdominal distension, reduced or absent bowel sounds, as the case may be. Of course, there will be so many other complaints, depending on what the cause is. Pseudo pneumoperitoneum will be from these, that means the differential diagnosis. It will be, necrotizing enterocolitis. It will be, abscess formation within the abdominal cavity by gas-forming organisms. It can be interposition of bowel, between, let's say, the liver and the hemidiaphragm. It can be a subphrenic abscess. What are the imaging modalities we would utilize in order to, identify, make that diagnosis, and then aid our surgical colleagues in order to intervene and then save a life, and then reduce the suffering of these individuals and these kids? We have plain radiography, ultrasonography, CT, fluoroscopy. Now, because they are children still growing, rapidly, growing tissues and cells, they are most susceptible to ionizing radiation. So our interest will be if non-ionizing radiation modality can identify, the pathology, then that is what we will go for first. So it means that ultrasonography would be, and we all remember too, that any individual that has an abdominal complaint, ultrasonography is usually more or less the first line of investigation, the primary investigation of choice, as we make, ultrasound, the point of care imaging modality for those who come to the hospital. Also, we'll remember when we talk about FAST, focused assessment, with sonography in trauma. So if it is trauma, maybe blunt abdominal trauma or whatever, and then we are suspecting that, it has traumatized the bowel and then there is a defect. Also, ultrasound can also help us. And then, of course, plain radiography also shows the pathology clearly. And so that is what will be, what will show the pathology the best. So the imaging modalities we are considering, it has to be safe. So, and I've mentioned that imaging modalities that we use in radiology can be subdivided into two groups. Those that utilize ionizing radiation to produce the images we see, and those that utilize non-ionizing radiation. For children, the safest modality will be the non-ionizing radiation modalities. The best modality, however, will be the one that will show the pathology and then exclude other differentials. The availability of the imaging modality would influence which modality we are requesting for. We cannot be requesting for a CT if it is a low resourcing area where they don't have a CT, you know, so we'll have to make do with the other modalities that can enable us identify the problems and then prefer solutions. The experience and the expertise of the radiologist also comes into play. You know, are the radiologists or the imaging experts there, are they proficient in looking at, you know, that, you know, imaging modality? So those are the things that will influence us. So in terms of imaging, plain radiography would come in quite handy. It is simple, it is, you know, relatively safe, it is not that invasive. Yes, ionizing radiation will be used, but in terms of radiation dose, it is quite low. So plain radiography will play a role in identifying air, you know, in an abnormal place in the abdomen. And the most important imaging modality in terms of plain radiography will be an erect chest film. So the chest radiograph would enable us. We know that air will rise to the topmost part of any container it is in, while fluid will gravitate, you know, to the lowest area. So air we would see in the upper part of the abdomen. So the imaging modality, plain films we can do are these listed here. We can do an erect chest film. We can do an erect lateral chest film. We can do an erect abdominal X-ray. The abdominal X-ray in this instance is not just the KUB we usually ask for. The KUB X-ray film does not typically show the hemidiaphragms. This one we must go up to show the hemidiaphragm so that we will identify air that is in an abnormal location. Cross-table lateral abdominal X-ray, supine abdominal X-ray, then the left and the right lateral decubitus film. The decubitus film is when the patient lies down on the table on his side, either the right side down, that will be a right lateral decubitus, or the left side down, the left lateral decubitus, and then we can identify where the air will rise to, because like we said, free air will rise to the topmost part of any container it finds itself. So on the erect chest film, what are we looking out for? We're looking out for air beneath the hemidiaphragm. The erect abdominal film too, air beneath the diaphragm. You know, and a left lateral decubitus film will show air above the liver, air between the abdominal wall and the liver, while a right lateral one will show the free air between the stomach or the bowel loop and the abdominal wall. The abdominal X-ray cross-table lateral will show us small amounts of free air too, and then it will give us various signs which we will list out. For large amounts of air, it will just show the rest of the contents of the abdomen, and we'll refer to it as its signs. So the abdominal supine X-ray will show us increased lucency in the abdomen. It can also show us certain ligaments, like the falciform ligament can be outlined by air. We can have what we refer to as a Rigler's sign, radiographic Rigler sign, where the inside of the bowel and the outside of the bowel is outlined by air. The air within the lumen will show us the inside, while air outside will show us. And then the inverted V sign of the umbilical artery ligaments can also be demonstrated. This is the positioning we see when we do our X-rays. They will be an erect chest film with the with the gonadal shield to shield the gonads. So we do this both in male and in females. So that is also doing our supine radiograph up, doing our supine abdominal radiograph, the erect abdominal radiograph, and then the lateral view. This is the lateral view. This is the the erect abdominal. This is the supine abdominal. So when we have an upright chest radiograph and there is a ruptured viscous, hollow viscous, we identify, so this we can see. So that's the Magenstrasse, the fundal gas shadow. That's the superior, the superior wall of the stomach, and then, or the fundus. So that is free air underneath the hemidiaphragm on the left. And then that is also this crescentic, radiolucency that we see, above the liver. So those are the things we refer to it as the leaping dolphin sign. And then when we have our lateral decubitors, that's the liver here again, the opacity of the liver or the shadow of the liver, and then that is free air. All this area is free air that we see. So it's a radiolucent area. Clearly, that's the thorax that we can, also identify. And then we have the right lateral decubitor radiograph, which is here. That's the chest, and then the hemidiaphragm. Look at all this is, quite a large volume of free air, which is radiolucent. And then we have air outside the bowel, air inside the bowel, giving us the Wriggler sign, So, and then we can have a cross-table lateral. We identify a cross-table lateral because we see the spine. The spine is lower down here, unlike the other radiograph I showed you, So this is the decubitors, that's the spine in the middle. So the the table lateral, the spine is down. So, and then we see free air all through, and then those are the viscera, the abdominal viscera displayed. So this might even be a tension pneumoperitoneum. It's quite distended, And then we have the chest film here, and then we have this lucency here in the middle. Of course, there is a sign, it's called the pupular sign, but, for the uninitiated, for somebody who is not looking critically at what we're, hoping to find, you might dismiss, look at the radiograph and say it's normal. But when we do a second one, when we do this will be our cross-table lateral again. Look at it. When we do our plain films, we ensure that a supine and then an erect, film that will show us, so that we don't miss out very small free air in the abdomen. Now look at this. It's a chest film, and then we see there is a very tiny crescentic radiolucency here above the hemidiaphragm. Below the hemidiaphragm, above the liver. So that is what we see when we have very minute, very small quantity. Of course, here too, there appears to be a little quantity, above the stomach, So that is it. So that's our cross-table lateral again. It shows us our Wriggler sign, and then it shows us air fluid level. Look at multiple bowel loops, but that is free air, a radiolucent area, and then we see the tiny radiolucent opaque, the bowel is radiolucent with air, outside is radiolucent with air, giving us our Wriggler sign. So free peritoneal gas, look at, this is referred to as football sign, so completely demonstrating the intra-abdominal viscous, and then we have the falciform ligament here, So almost like the football is not the soccer ball, no. It is the rugby ball or the Australian rules ball or the American football one. So that is what we refer to as the football sign. And then here we see gross air within the abdomen, and then we see the abdominal viscera displaced to the ear. The patient will be in real pain and difficulty and really, screaming. So we have to do the best we can to relieve the challenge. Now we also have free gas here. So that's the stomach with, a tube, the NG tube inside. But over the liver, shadow, we have this area of lucency. So here is not as opaque as this area. So this is what we refer to as the, lucent liver sign. So that is also telling us. Of course, with this, if we are, we are in doubt, we'll do our cross-table lateral, or we'll do, our decubitors views, and then we'll be able to identify. So the bowel-related signs are the double wall sign, which we refer to as the Wriggler sign that I've just shown you. You're seeing the inside of the bowel and outside. And then the telltale triangle sign is also a modification of the Wriggler sign. For that one, we are seeing two bowels, looking at their walls, and then seeing the anterior abdominal wall as well. So that is referred to as a triangle sign. These are bowel related. And then there are the signs I've mentioned some of them. We'll still see, other views as well. The right upper quadrant related signs, the subphrenic free gas. I've shown you the cupula, and I've shown you or we have seen the leaping dolphin sign, the cupular sign, which is seen on the supine film, the continuous diaphragm sign, the Doge cap sign, the hepatic edge sign, the lucent liver sign, the periportal free air sign. So, and then those that are related to ligaments within the abdomen, the falciform ligament sign, the lateral umbilical ligament sign, also known as the inverted V sign, Uricus sign, and then the football sign. So here we see the Wriggler sign. So look, that's free air, that's the Bowel loop. So we see the inside, we see the outside, that's the lumen. So that tells us that there is free air within the abdomen. So this is our Wriggler sign. And then, you know, we have the lucent liver sign. This is a diagrammatic illustration. So that's what this is the liver, and then you see on the supine film, the air will rise to be above above the liver. So we'll see an area that is more lucent than normal. So on the lateral view, we'll see it, and it's like that. So that's our lucent sign. We saw what the liver looks like. Now you can see, a lot of dilated bowels, all over it, but it appears lucent. There will be another one I will still show. But look, there is air all through, outside the bowel loop. Look, there is air outside. There is air outside here. So, but within the abdominal cavity, so we refer to it as the reduction in liver's radio opacity or an increased radiolucency. So it's referred to as the liver lucent sign or the lucent liver sign. So we have the cupular sign where the arrow is demonstrating. So we have a lucency in the middle here, which I had shown us one already. So this one is like, the dome, so it's referred to as the cupular sign. So that's it here again, the cupular sign in the middle, the area of the central tendon of the hemidiaphragm. So we see that. And then the leaping dolphin sign, I've shown us this already. Look at it, and then that's, show. Then we have also the football sign, large amount of gas, all over, the mid-abdomen. And then we also see that this is supine, that is the erect. It shows us multiple air fluid levels within. And then we also see this, so telling us that there is free air within the abdomen. And then we have the telltale sign. This one, yes, the radiograph is not in a child, but, I put it here just so that we can identify what it means, So we can see bowel loops 1, 2, and then here showing us the bowel wall. So this will refer to as the triangular sign or the telltale sign. So showing us 2 bowel loops and then the wall. And then our football sign. That's our falciform ligament. That's the gas all over, It shows us radiolucency all over the abdomen. And then when you do your lateral or when you do your cross-table lateral, as the case may be, look at how big the free gas is within the abdomen. And then that's the same falciform ligament sign. That's the falciform ligament, here. And then look at, so this area also shows us the liver sign, and then that's the liver, that's the NG tube within the stomach. So here too, still showing us the football sign, and then the falciform ligament sign as well. So the lateral ligament sign, which is an inverted V sign, also known as the inverted V sign, is due to air demonstrating the lateral umbilical ligaments. So we see that here. Look at where these arrows are. So we see the lateral ligaments. So when we see this, we know that we don't typically see this in a normal abdominal radiograph. But when it is now demonstrated by air within the abdomen, we can make out these ligaments. So that's it here again. So we have free air. And then the Uricus sign, which is the medial umbilical ligament that rises or runs from the umbilicus to the urinary bladder. So we see that sign as well. We see that sign as well. So that's it here again on this side, the Uricus sign. And then we have the pneumoperitoneum. So air can be in the region of the retroperitoneum. And how do we know? When we change the position of the patient, the air remains the way it is. So here you can see a very narrow strip of gas, under the liver, that's the liver, that is the lateral border of the kidney, the right kidney. So this is where it is. So we can differentiate it from another sign that we'll talk about, the liver edge sign. So that's our continuous diaphragm sign. Air under the diaphragm, demonstrating the entire diaphragm. Of course, that's where the central tendon will be. And then, so on either side of the hemidiaphragms, we're seeing, the gas. Falciform ligament sign, I've also mentioned this. The hepatic edge sign is what, we would now mention that I said it looks like the pneumoperitoneum, but it is broader. It is said to be, like almost looking like a cigar. It is not the tiny strip we saw for the pneumoperitoneum. So you can see the hepatic edge sign, it is broader, it is like a cigarette, like a cigar, so, and then you can see the opacity of the liver on the right side. So that's it again. And then the Doge cap sign is a triangular radiolucency, over the liver, the opacity, the radial opacity of the liver. It can be as a result of air in the right paracolic gutter, the pouch of Douglas, the anterior liver of the anterior surface of the liver, and then the hepatorenal fossa. The Doge cap, you can see here, almost looking like, the caps that is worn by the Pope. If you look, almost looks like it. And then, of course, because it is called Doge, we also have the man who is handling the Department of Government Efficiency in America, Elon Musk, here too. So he too has a cap. That is not the face cap that we're looking at, but this would enable us to remember that this Doge cap sign exists in order to identify pneumoperitoneum. The football sign I've already described, large bowel, large, quantity of gas all over the abdomen with the falciform ligament. The falciform ligament almost corresponds to what you see here, the stitches on this ball. So that is why, like I said, it is not the soccer ball, which is spherical. This one is oval shaped or oblong, as you might call it. So, and then the differential diagnosis, we said one of it was interposition of bowel loop in the abdomen, between the hemidiaphragm and the liver or the stomach. So we have this, which is referred to as the Chilaiditi syndrome, bowel interposition. We differentiate it because we can see the hostrations, that demonstrate it. Of course, there is significant elevation of the hemidiaphragm in this instance. So this, when we see the hostral markings, we immediately know that no, it is not, bowel perforation. So that's it here again. That's it here again. Now in this instance, disease conditions or anomalies can coexist. Here we have the Chilaiditi syndrome. Here we have the hostrations telling us large bowel, the hepatic flexure. Also here, we also see, bowel loop interposing between the stomach and, the hemidiaphragm. But there is also still free air. There is free air here. This crescentic radiolucency will identify clearly in the left, subphrenic area. So that still identifies. But if we have doubt, then we can still turn the patient, do a cross-table lateral, do, or a decubitus view to be able to identify the pathology clearly. So pneumatosis intestinale, this one we see especially, people with necrotizing enterocolitis, young children. So we see dilatation of the cecal area and then the ascending, colon. But here we have tiny air bubbles. Look at it within the wall. So this one, no matter how, when we do our decubitus view, we do our cross-table lateral, it will remain where it is because it is within the bowel. So that's the differential intramural gas. Now, what are the advantages using plain films? It is readily, our X-ray machines are readily available. They are simple and easy to use. And then the interpretation, the plain films, also easy. It has high sensitivity. It is not expensive. What are the limitations? In order for us to have an idea of where the gas actually is, we might need to do 2 views, one supine, one erect. Even when we do a chest erect, we can also do an erect, a cross-table lateral view. Ionizing radiation is involved here. And like we said, we will limit the use, in young children. And then it requires standardized procedure and technique. What I have not mentioned is that for us to have the gas rise to be, this patient should at least be on supine. They should be like that in about 5 to 10 minutes, so that we can identify the gas can rise to the highest level, and then we'll identify it. Abdominal CT is the most sensitive method for us to detect peritoneal free gas. And with it, very of gas can be visited. It said that about 1 to 3. Yeah.
Yeah, sorry to interrupt. We had a question that was asked earlier from Dr. Oyania. He said, for neonates, what views would you prefer the surgeon request for in terms of plain radiography?
Okay, for neonates, we'll do our cross-table lateral. The cross-table lateral will be advisable, yes. And of course, remember that we can restrain them, with our restrainer. So we can also still do it, the child can be held up, and then a chest film can be done too, an erect chest. But the cross-table lateral will be fine, because the child is lying down. We'll do a supine, and then we'll do a cross-table lateral. So that will suffice. A cross-table lateral will do.
Yes, sir. Neonates. And then the second question he asked is, a neonate with bilious vomiting, what would you prefer residents or surgeons request for first? Ultrasound scan or plain X-ray?
Ultrasounds first. Ultrasound. Bilious vomiting.
Yes, sir.
Yes. Ultrasound. Like when we started, I mentioned that usually abdominal, complaints, the next thing we usually want to do would be an ultrasound. Because now bilious vomiting, it can be, pyloric stenosis. It can be something else which we can identify too. It can also be, the next topic we'll be looking at, intussusception. So, sonography will be the first thing that we need to do for such a child. And then the abdominal radiograph can also suffice.
Thank you, sir.
Okay. So CT is the most sensitive, but like we said, it utilizes very high, doses of ionizing radiation. So radiation, exposure for these young ones, we want to limit as much as possible. But CT is most sensitive because it can detect 1 to 3 mils of free gas inside the abdomen. Also, other structures, abdominal structures can also be identified and looked at. And then CT has numbers attached to various tissues, so that we'll be able to say, oh, if we see this number in our region of interest area, we know that it is air, we know that it is bone, we know that it is, soft tissue, we know that it is blood. And then AI too is, coming in to also help us make that, differentiation. So these are the Hounsfield units for different structures within the body. The bone will be plus 1,000. Air will give us about minus 1,000. But of course, it can be less, because remember, we have other structures within the abdomen. So, it can be minus 800, minus 700, as the case may be. But you can see, so when we, even if we are not sure of what is there, and your resident or a doctor describes and says the region of interest number in that area is minus 1,000, you immediately know that it is free air, and then you give the necessary advice. Of course, we remember that CT would also show us the other structures within the abdomen. So that's our CT, different windows showing us the falciform ligament sign. And then that's free air. The free air will be hypodense. And then that's our Rigler sign. That's a bowel here. That's the inner part of the bowel. That's the outside. That's our Rigler sign. It's the same thing here, different window. This is the bone window. This is soft tissue window. And then we'll have the falciform ligament sign. And then we also have the regular sign, and then we'll have the free air, inside. So free periportal gas sign, we can also identify when we see free gas within the liver, and then the portal hepatis area, So free gas, look at very minute, small, hypodense area. So the cursor here, who knows, it might give us maybe minus 600, minus 700, and then that's also free gas. And then we can identify the liver, the kidneys, the various bowel loops. We can identify them in our study. That's massive intraperitoneal air, also showing us the regular sign on either side, which I've already described, And then the same thing, CT axial views, we see this free air, regular sign, it's anterior, the abdominal wall. This also would be our triangle sign on CT, because we see two bowel loops here, we can make out them, and then the anterior abdominal wall, so we also see. And then in this view on the left, this is a contrast axial section of, a CT, post-contrast, administration, and then here we see the hypodense area, who tells us, that there is free air. That's the gallbladder. That is gas. Also, the dark hypodense area shows us the gas. And then around it, we see a hyperdense. We see this. This is fluid. This is the contrast that, was given orally. Of course, it has, gone out, leaked out, into the peritoneal cavity. So that also tells us. So same from that loop between the liver and the bowel wall and the anterior abdominal wall. And then CT.
Dr. Agi, sorry to interrupt again.
The best imaging modality in terms of sensitivity. Yeah.
Yes, we have another question that I think is really good to address now. The question is asking, I believe this is about the Hounsfield units numbers. It's asking what determines the numbers for each organ, as in, you showed a slide earlier that
Yes. Okay. What determines the number is the content of the tissue, that is in that area, the density of the tissues. That is what determines the number. So the denser the tissue, the higher the number. And these numbers were worked out, by the man who discovered it, Jeffrey Hounsfield. So now you remember that bone itself is the most dense structure within the body. So the bones have the highest, number. Compact bone. The spongy bone, remember, we have the medullary bone, which is spongy bone. It is not as dense. It won't give you that number, that amount of, the Hounsfield unit. Of course, if there is a metal here, the metal will be giving you readings close to maybe, 3,000, like that. So you just know. But you notice that it will be very, very bright, very hyperdense on this. Fat, look at where fat is on our slide here, this axial, section. So fat is usually not as dense. It gives us a Hounsfield unit of -100. So when, you have a Hounsfield unit of -100, it is fat in that area, and then look at for the liver, it is giving us +100. So what determines the Hounsfield unit, or what we also refer to as the attenuation number, or we also call it the CT number. What determines it is the density of that tissue, the content of that tissue. So tissues that have calcium within will have a higher one. Metal will have a higher Hounsfield unit. I hope I've addressed that.
Thank you, sir.
Yeah. So we continue. We'll continue quickly. Sorry, I had to go all through. We talked about the triangle sign. We talked about fluid, contrast, leaking out from the bowel. It also outlining the gallbladder. Look at air outlining the gallbladder wall. That's air here as well. And then this air now, when we have our Hounsfield unit, it might be maybe -400, -500, as the case may be. And then we talked about the interposition of bowel loop. That's our liver. That's, a bowel loop. We see that because we see the auscultation. So, and then we're looking at the advantages. I talked about it being the most sensitive and then specific, and then have CT numbers or hands-free units or attenuation coefficients that would tell us what the tissue or what the structure is. The limitation is ionizing radiation. The dose is very, very high for exposure, and we don't want to expose children, to that. It's been found out that if somebody is exposed to, let's say, have an abdominal CT done, a child, that quite a number, maybe 21 to 30% of those who are exposed to a CT earlier on in life, 20, 30 years down the line, they found out that, they came down with, in neoplasia. The cause relation is not known anyway, but that is what the study has found out. CT is also very, very expensive. So in low resource areas, you can't ask them to go and pay for a CT. In Nigeria, a CT scan can cost maybe 50, 60,000 of our money, while a chest film will cost like 5,000 naira. So you can see it's almost 10 times the amount. It is not readily available. Not every institution have, the CT, and then oral contrast can obscure other, Ultrasound is one study that can be encouraged for us to perfect. It is useful in the hands of those who have perfected the technique of identifying, gas within the peritoneal cavity. So ultrasound, as we know, first is one of the first imaging modality to image soft tissue, challenges, abdominal, problems or clinical scenarios. But it is useful in the appropriate clinical setting. And the transducer that we would use that would enable us make good identification of gas will be a linear array transducer, high frequency transducer, about 10 to 12 megahertz. A curvilinear probe, with low frequency can also help, but it is not ideal. Remember, in ultrasound, the higher the frequency, the lower the penetration. So it will usually show you things in the near field, things that are close to the surface. And like we have agreed in our, getting to this point in our discussion, that air will rise above, to the highest point, in any container that you put it in. So when the patient is lying down supine, the air will rise to the, just beneath, the anterior abdominal wall. So the linear array transducer will be the best that can be used. It is more sensitive. And then when we do it, we can readily find, demonstrate, pneumoperitoneum. So like I said, sonographers, sonologists should be, adequately trained. The reason is that if we're not adequately trained, then we can, if we are relying on ultrasound, we can say it is, that there is no pneumoperitoneum when there is, and that can be very disastrous because the patient will be discharged, and then by the time the patient comes back, some hours later, the disease condition would have deteriorated. So ultrasound findings are sensitive, but they are usually not taken alone. So a patient comes and you do your abdominal sonography, like we said, a child comes, a neonate, who maybe that has been mechanically ventilated, and then we'll have a pneumothorax, pneumomediastinum, and then it seeps into, the abdomen. So, we will do our abdominal scan because of the challenge, and then we can identify it, and then we'll do our plain radiograph to support. So abdominal ultrasound is able to identify distinct echogenic stripe-like bands overlying the splenic and hepatic flexures. This will indicate pneumoperitoneum. So the ultrasonographic signs of pneumoperitoneum are enhanced peritoneal strip sign. Remember we mentioned when we talked about our brief anatomy, radiologic anatomy, which we know already, that we have the parietal peritoneum, we have the visceral peritoneum, and covering the abdominal viscera. So the enhanced peritoneal, strip sign will be regarding the parietal peritoneum. So reverberation artifact, the commectile artifact, shifting air sign, dirty shadowing, which we would also see. So it can also be combined with movement, which we usually do with ultrasound. You can move the patient a bit, and then we'll see that the air moves with movement, and that will tell us that there is free intraperitoneal air, with changing the patient position. And then contrast can, be used. Software, just like the CT, just like the CT is being aided by, AI. Ultrasound too, there are softwares that can enable us to improve our diagnosis using ultrasound. So, and then that will be maybe in time to come the best imaging modality. So here we see what the normal is. Look at the subcutaneous tissue. That's the muscle of the anterior abdominal wall, and then that's the peritoneum. Yeah, so we can see how clear it is. But when there is air, we can now make out this hyper-echoic or echogenic area. Look at it, and then that's it. So we have this enhanced, peritoneal strip sign. So we're doing a scan. We're not, we should have a high index of suspicion anyway, and then we'll see this. We can move the patient a bit, and then this would move. We know that, look, this shadowing we are seeing is because of free air. And then the reverberation artifact, you can say reverberation, like somebody going to a high mountainous area. When you shout, it echoes. So these are like echoes, reverberation that we will see. It will come only when there is free air within. And then there are gas bubbles, these tiny hyper-echoic or, echogenic spots, within a fluid area. So this tells us that there are bubbles of air within. And then we also have, we'll look out for peristalsis as well. If the dirty shadowing we see here is within the bowel, it will move. If it is not, then we'll know that, it is. And then we'll have the reverberation artifact. So that is it here again. So reverberation artifact. That's free fluid inside, which is, echolucent or echopore, or echo-free, as we would say. So there is free fluid. And then that is free air. That's our enhanced peritoneal strip sign. And then that's our reverberation, So that's our reverberation, and then the enhanced, peritoneal strip sign, here. And then this almost gives us like a comet tail appearance, as if there is, an acoustic shadow accompanying this. So these are the things we see, and then it is, it gives us a high index of suspicion for free gas inside. So that's it again. So that's it. The soft tissue peritoneum, and then we'll have this dirty shadowing, that we see. So the same thing here. So we'll have our comet tail appearance. Look at like the comet, and then that's the tail, that's the gallbladder, and then so quickly our comet tail, the Halley's comet. So that's it again. Our enhanced peritoneal strip sign. So that's air, giving you what sometimes we can also refer to as dirty shadowing. So that's the liver, that's the left lobe of the liver. And then look at how this appears, like a dirty shadow. So that's what we see. This we can also go, on the net, we can actually follow in scans. So that's our dirty shadow again, the echogenic areas, multiple like bubbles, and then look at the dirty shadowing after it. So when we can also see, that. Now, what are the benefits? Ultrasound is easy to use. It is inexpensive. It is non-invasive. Does not use ionizing radiation. It can image the other viscous because it is a cross-sectional imaging modality. And then what are the limitations? It has, it is poor, it's not very good at imaging those who are obese. So an obese child, might find it difficult. Large amounts of intraperitoneal gas can also limit the quality, of what we see. It is operating. I mentioned it earlier in introducing ultrasound that individual sonographers, sonologists have to be adequately trained, so that they will be able to identify this. There is a maxim, there is a saying we use in radiology. We say you know what you look for, and you look for what you know. So you must have a hand, and then you'll be able to identify it when when it comes up. So that is it. Now, fluoroscopy is the long-standing imaging modality of choice to visualize the site of the perforation. Of course, fluoroscopy can also show us the free air within the abdominal cavity. But fluoroscopy in this instance is being used to identify where did the perforation come from, having certified that this patient has free air in the peritoneal cavity. If it is performed as a primary imaging modality, it should be performed with water-soluble contrast medium, because if we use barium, then it will cake, it will cause chemical peritonitis, it will worsen the patient's condition, lead to more, morbidity and mortality, as the case may be. The contrast we usually use is, a contrast referred to as gastrographin, or we can use the dilute low osmolar contrast agent, iodine-containing agent, iopamidol. So fluoroscopy is there to help us identify and pinpoint where the leak actually is. And then with the surgeons, the pediatric surgeons will now go in, be more focused in their search and repair, procedure. Of course, not every center in low resource countries, not every center would have a fluoroscopic functional fluoroscopic equipment. So the moment it has been identified that there is an intra-abdominal perforation, the surgeons will usually not waste time. They will want to go in. So here we see a patient that has a gastrotomy tube here, a supine radiograph. It has the contrast, and then the there is this, as if there was removed and then a jejunostomy tube was now introduced. So that's the tube, the gastrostomy tube again. And then this, when contrast was introduced, you can see it seep out, come out. So that tells us that the small bowel has been compromised. And then the surgeons will now go in and then, do the needful. So this one too still shows the same thing. The tube, this one, the tube almost comes down, down to the pelvic area. And then that's a cross-table lateral. So this cross-table lateral now actually demonstrates, so like I said, we can combine the procedures that we do. That is another, an enema. So this one also tells us that there is a leak, of contrast, at the level of the rectum. So this also can tell us, in terms of, and then yes, there is a CT study here, that is also put beside it. So what is the diagnostic algorithm? Plain radiography will be the first imaging modality if, that diagnosis has been, made. But if the patient has been sent for sonography, sonography in the best of hands would be, what will also support, and then it will also identify if there is fluid and then there are other problems. CT is the best imaging modality, but for a child, for those still growing, CT will be the last imaging modality when we cannot determine what the problem is. Then CT will be done. So plain radiograph will show us the leaks, will show us the free gas, show us the pneumoperitoneum. Ultrasonography, yes, contributes. So either of them, depending on what the center has, can be used interchangeably. Like I mentioned, in our introduction, a patient that has abdominal, problem, ultrasound commonly is the first thing we'll say, do an ultrasound. The question that was asked, a neonate, it will be ultrasound. Oh, the patient is vomiting, bilious vomiting and all that, ultrasound. And then when we identify that our suspicion is there appears to be pneumoperitoneum, we'll now do a plain film, a cross-table lateral or, a decubitus study. MRI is not commonly utilized. In summary, plain radiography is the primary imaging modality of choice. Ultrasonography in trained hands can be combined with plain radiography. Abdominal CT is the best modality in terms of sensitivity and specificity, but in this age group, we cannot, but it will be the very last resort that we would use. So that's our references. I think thank you for taking some questions, but if there are still questions, we can go ahead and take them.
Yes, sir. We have two questions. Well, one question and then I think a comment. The first one is by Dr. Prose. She said, in conventional radiography of a case of pediatric pneumoperitoneum, wouldn't the acute abdominal series supplemented by either cross-table or lateral decubitors be applied depending on the clinical status of the child?
Yes, I said it will apply. You know, is it the same bilious vomiting or well,
think,
remember
no, I think it has to do with like which view should you start with first, if I'm understanding the patient well.
Okay. For a neonate, you know, quite small, like I said, we'll do a supine film, we'll do a cross-table lateral. We'll do a cross-table lateral. That means we're not moving the child. The child is just stationary. We use a vertical beam and then a horizontal beam. But what I said still applies in this instance, that child will still be investigated using ultrasound as well. So ultrasound would also be applied. You know, the ultrasound, yes, can confirm the air. Ultrasound now can also look at if there is, you know, ascites, if there are other pathologies within. That ultrasound can also be applied, you know, in terms of imaging. Now, for such children, if we have to use CT or an MRI, yes, then that would now be the progress. But the first imaging modalities that we would use would be our plain films and then ultrasound.
Thank you, sir. And for our audience, today we're going to run a little bit long because we still have the session on intussusception. He'll be starting very soon. And then Dr. Agi, the last comment was from Dr. Mohammed Abdullahi. It says, I think with good sonographer and also for safety, we try to maximize the use of ultrasound. Generally, proper examination reduces the overuse of imaging.
Yes, I agree, which is what I said, that, you know, for every you know, clinical scenario that will involve the abdomen, we want the ultrasound is like the extension of the clinician's, you know, fingers, you know, or hands. So ultrasound can be done when that is identified. But remember, I said that in, you know, in a poorly trained, in a hand that is not, you know, proficient, then it can become you know, something that, you know, we wouldn't be able to clearly identify what the problem is. So even when in that high degree of suspicion, one plain film, the radiation dose is not much. It is in question, or it is the situation of saying do a CT. That is where, yes, that would be grossly or, you know, really discouraged. You know, so a plain film will just confirm it.
Thank you, sir. Do you want to transition to the other one?
Yes.
If folks have any other questions, please feel free to put it in the chat or ask. Unmute yourself and ask.
So this one, we will be faster because of time. We'll be faster. So we'll be looking at intussusception in children. We'll be looking at intussusception. Wisdom is the principal thing. King Solomon told us we're here to get more wisdom, you know, get more understanding. The outline is looking at it in this way, you know. Intussusception is defined as when one segment of bowel is pulled up, invaginates, or, you know, protrudes into itself or a neighboring lip of bowel by peristalsis. It is important, you know, it is an important cause of acute abdomen in children. Now, with this, we should realize that intussusception usually, you know, proceeds in an antegrade direction. That means it is from the proximal bowel to the distal bowel and not the other way around. And then it can be from the small bowel into small bowel, or from small bowel into large bowel. So that is what we see here. A child a child, it is said that intussusception would occur in a child that, the clinical history is, usually normal child, playful and all that, then suddenly starts crying, writhing in pain. So that's what we'll have here. So that's the bowel entering into the distal, part. And that's what be in a normal setting. So comes out and then entering the distal, bowel. For the bowel usually transmits fluid, solid and liquids, from one part of the bowel to the other. And when there is this intussusception occurring, there is an obstruction. So what we'll have would be there will be a pre-stenotic dilatation, and there will be post-stenotic collapse, which will, stenosis is a part of the bowel into another, which will cause obstruction, the lumen. It will cause occlusion due to compression of the blood vessels and then lead to ischemia. If the intussusception is long-lasting, it may lead to what? Necrosis, lead to peritonitis. It may lead to perforation of that bowel, and then in shock may set in and possible death. To make this diagnosis, imaging is very, very crucial. Imaging is crucial. Of course, clinical information would also make do with. So the purpose of our talk will be to review the disease condition, enable us to have the imaging pattern, which we'll recognize, discuss the best practice for us in terms of making the diagnosis and then treating it. So radiologic anatomy, we know the foregut, midgut, hindgut. The cross-section we've already taken in the other study, discussion of pneumoperitoneum. The arterial supply is from the celiac trunk, the mesenteric vessels, and then the venous drainage goes to the portal vein. And then, like we said, the peritoneum has the visceral part, and then and then it has, and then it has a parietal part that encloses spaces, showing us the lesser and the greater, sacs, as well as the paracolic gutters. The blood supply we've already discussed. The bowel wall, like I said, we know. What is the pathology? How does it occur? It is said to be due to hypertrophic lymphoid tissue that might follow maybe even an upper respiratory infection in a child. Congenital factors such as Meckel's diverticulum, duplication cyst, intestinal malrotation can lead to it. Inflammatory lesions can also, give rise to intussusception, one bowel loop telescoping or invaginating into another. Trauma, blunt abdominal trauma can give rise to mural hematoma, the wall of the bowel, giving rise to, blood collection. And then that will be what will, tip the bowel with peristalsis to telescope into one another. Neoplasia, either benign or malignant, can also contribute. The prolapsing part of the bowel is described as intussusception. The distal part is intussusceptions. So the receptor or the receptacle is in intussusceptions, while intussusception is the prolapsing part. Venous return usually, or remember that like we talked about the anatomy, there is the bowel wall, and then the mesentery where the vessels are there. This will also be, and will enter the intussusceptions, and then it will compress the venous return. When there is no venous return, there will be edema. With edema, there will be further restriction in blood flow so that arterial supply will be compromised. And then ischemia, infarction, necrosis can ensue. And then, perforation as the case may be. So we've already seen this diagram. So it can be classified into permanent and then, transient. Permanent intussusception is the one that would need our surgical colleagues to, take care of it, reduce it. It cannot be reduced by the other non-surgical procedures. Then we'll have transient intussusception that can be considered physiological in both children and adults. It's reversible on its own. And then we'll have and then the epidemiology, we have said that 95% of intussusception occurs usually after the first 3 months of life, and 95% occurs in children. The clinical presentation, there is a classic triad of abdominal pain, vomiting, right upper quadrant mass. And then in some instances, the child will pass mucus and blood, which is referred to as red current. Or when the digital exam is done, there will be blood on glove fingers. Only a small percentage, about 20% or less of intussusception cases present clinically. And then we also know that in about 15% of those who present, abdominal pain is not usually part of their problem. The physical exam findings will show a palpable, soft tissue mass in the right upper quadrant, which is usually described as sausage-like, and then there will be paucity of gas, paucity of gas in the bowel loops in the right lower quadrant. And then sometimes, like we said, the red current, which we will see. So on the left, you see what the child can pass. This one is just, like ketchup. Quite a number of people in our setting may not have seen what a red current is, but it's like ketchup. So there is a in terms of the location, the commonest is in this region of the terminal ileum and the cecum and ascending colon. So ileocolic, 75% of intussusception. Ileocolic is the second most common. Gastric intussusception is quite rare. What are the imaging modalities we would apply? Ultrasound, plain radiography, fluoroscopy, MRI, CT, as the case may be. So in applying the same principle we did regarding pneumoperitoneum, the safest imaging modality will be that which utilizes non-ionizing. The best imaging modality is that we will show us the pathology and exclude differentials. Availability of that imaging modality will influence which imaging modality is requested for by the clinician. And then, of course, the experience and expertise of the radiologist will come in. The radiological signs of intussusception are: 1, pseudokidney sign, which is like, an ultrasound, a hypoechoic, or an echo area, on ultrasound that, the shape of which will resemble a kidney or a bean seed. And then we'll have the target sign, which is also referred to as the donut sign or the bullseye sign, which are concentric rings of alternating echo-rich or echo-poor areas on ultrasound, or hyperechoic and hypoechoic areas, or echogenic and echolucent areas on ultrasound. The crescent sign will be, a crescent-shaped gas pattern that we will see on plain films, abdominal X-rays. The meniscus sign will see a soft tissue density that forms the crescent shape on plain X-rays. Ultrasound is our first imaging modality of choice. It has virtually zero false negative in terms of identifying, intussusception. And it is a reliable screening tool for those who are, in children. The classic findings in intussusception will be, however, if we find it, will be, investigated with an enema, which will be both diagnostic and, therapeutic. So it is the gold standard. But ultrasound would help us because before we apply, enema treatment in terms of non-operative treatment, we must confirm that the bowel has not undergone necrosis, that the bowel has not undergone ischemia if it has stayed for too long before it presented to the hospital. So that means that ultrasound is still the imaging modality of first choice. So, ultrasound will show us the target sign, which is also the donor sign, the pseudokidney sign, the crescent sign in the donut sign. And then if there is absence of blood flow, when we do our color flow Doppler, it is a contraindication for enema reduction or non-operative reduction. Free fluid within the intussusceptum and free fluid in the peritoneal cavity is also a contraindication. A lead point within the intussusception can be a lymph node. Well, let's note the longer and the larger the intussusception, the more likely it is an ileocolic. Of course, we have said the commonest is ileocolic. So if it is larger in terms of the diameter, 2.6 centimeters and above, we know it is most likely and it is ileocolic. If it is also in terms of length greater than 3 centimeters, it favors ileocolic intussusception, So, and then the clinical scenario that will be most consistent with uncomplicated clinical cause source will be when the diameter is less than 2.5, when there is still motility within the wall, when we do our sonography, when there is no identifiable lead point, when the length of the invagination is less than 3 cm. So that's our ultrasound still images. On the left here, this is, a transverse view or an axial view. That's a longitudinal referred to as our rings of echoic and then hyperechoic area. That's, the bowel inside. So this tells us that there is intussusception. When you now open it up by doing a sagittal view, what it gives you is what looks like a kidney appearance. Those are hypoechoic areas that almost gives the calyces of the kidney. So this is the same thing, crescent sign, so hyperechoic, hypoechoic, hyperechoic, so those concentric rings. So that is what we see, concentric rings again, the same thing, ultrasound still image showing us target or the donut sign, as the case may be. This will be our, kidney sign, look at two bowels together, and then that's the hyperechoic area, and then the hypoechoic, surrounding it. So this tells us that there is intussusception, and then intussuscipiens, so that's our pseudo-kidney sign, like the kidneys, the calyces of the kidney. So that's what we see to confirm that, yes, there is a mass. Of course, it will be solid. So that's it here. And then when we put our color flow, there is color flow within the intussusception. So this tells us that, yes, we can use enema in order to what? Reduce it. And then there will be no, adverse effect. But if this is done, color Doppler, and there is no flow, then we cannot continue to say, let us reduce it with enema, because it means that we'll be reducing a dead bowel, which will now undergo, necrosis and then, perforation. So plain film here that shows us. So this is supine radiograph showing us dilated bowels, which we see mainly on the left side of the hemiabdomen. And then look where the arrow is our crescent sign, our crescent sign. This looks like the meniscus sign, the solid mass that has given rise to this obstruction that has led to the dilatation. So this will be our pre-stenotic dilatation. Here, we're not really seeing any, bowel loop, the bowel gas here. Now, the ultrasound of this, abdomen, this would be our axial or transverse scan. So that's our hypoechoic, periphery. That's our hyperechoic core. That's our target sign, donut sign, bullseye. And then when we open up doing the longitudinal scan, we also see, so this will be our intussusception, and then this will be our intussuscipiens. So, and then we would have to do our color flow to be sure. So the same thing, plain abdominal radiography, may demonstrate the elongated soft tissue mass, which I've already shown us in the right upper quadrant. And then it, would also give us the bowel obstruction, because the lumen of, the bowel will be obstructed, giving you a pre-stenotic dilatation, which I mentioned, and then a post-stenotic collapse. For the pre-stenotic area that there is obstruction, we would have air fluid levels and bowel dilatations. We will see the air fluid levels in our erect radiographs or cross-table lateral radiographs, and then we'll see bowel dilatation in our supine studies. So like this is supine study. What we're not seeing air fluid levels, rather we are seeing gross dilatation of the bowel lobes. So radiographic signs will be a soft tissue mass that we'll see, which we've shown you, the crescent sign, the bowel dilatation on supine film, which I've also shown, air fluid levels on erect or cross-table lateral, and then the absence of gas in the lower abdomen or the pelvic cavity. So this image shows us gross dilatation of the transverse and then the descending colon. Here, we're not, it's not certain if there's a mass here, but this is where ultrasound would also help us, because ultrasound would identify if the mass, wherever the mass is, that, the intussusception, it will show us, clearly. So the same thing here. So we've seen the right hemiabdomen has paucity of gas, the dilatation of gas, bowel loops on the left, and then there's this soft tissue mass here, which we can actually interrogate or investigate with our ultrasound, to help us. So that's the same thing here, soft tissue mass on this side, and then dilatation of all the bowel loops, and then here too, there's, these ill-defined E's or opacity here, and then dilatation of both small and then the large bowel loops. So that's the circled area showing us the crescent sign and then the mass. This appears to be the mass. And then you can see small bowel loops identified because we can see valvulae conniventis. So small bowel loops markedly dilated. And then that's the mass here. We can also interrogate. The rectum still has the gas within it. So that's it. Left hemiabdomen has the bowel gases, and then the right hemiabdomen, you can see this is. That's what appears to be the meniscus sign, the soft tissue mass, and then so that's it. Lateral decubitus. Fluoroscopy, contrast enema remains the gold standard to demonstrate and then to non-surgically treat intussusception. Non-surgically treat. I must say here that, of course, it has to be in a center, in a unit that has the fluoroscopic machine. The surgeons will be there with us. The surgeons will be there, because it will be a multidisciplinary team approach. If the non-surgical reduction fails after 3 attempts in about 3 to 5 minutes, then it has to be surgery. Now, the contrast that we would use, it has to be water-soluble contrast medium, which I have mentioned already before. We cannot use barium, because if there is perforation, because of the time it has taken for, the reduction to be attempted, then it will, worsen, there'll be peritonitis, and it will worsen the child's, clinical state. The occluding mass, prolapsing into the lumen would also give us a coil spring appearance or coil spring sign. The absolute contraindication for the enema will be perforation, which needs to be treated surgically. So that's our, contrast study enema. So it shows us from the descending colon, the rectum, rectosigmoid, descending, the splenic flexure, the transverse colon. So that's where we see, the mass coming in. So that is it. So this is what the contrast enema will push back, and then we'll push back. And how do we know that we are successful? The contrast will now be free, will freely flow, even into the small bowel through the ileocecal valve. So that with that, we are sure that we have reduced it. Remember, we have said there is a caveat or a condition for us to attempt the enema. Forgive me, this shouldn't be barium. It should be contrast enema. Forgive me. Now, we have said we must do ultrasound to confirm that that bowel is viable, that there is, blood flow. So this one, the enema has demonstrated the descending colon, the splenic flexure. The intussusception is almost at the level of the splenic flexure. So the contrast will now push back this until it gets to, the contrast will now flow freely. So this is it, a plain film that shows us. So this middle here, the soft tissue opacity that we see, radio opacity, is the intussusceptum. And then that's the intussuscipiens, the gas all around it. That's the gas also outlining the transverse colon here, you know. And then the same thing here, we're seeing the gas all through. And then look, that's our ultrasound, color flow Doppler, telling us that yes, go ahead, you know. So the surgeons are there, then we can attempt under imaging guidance. So it can be done under ultrasound guidance, it can be done also under fluoroscopy. But what we have said earlier applies. We want to limit radiation, ionizing radiation exposure to children. So we want to do it under ultrasound. So that's our NMI again, you know, that shows us the intussusception, you know. So that's it again, you know, air enema, and that's the leading, you know, margin in terms of treatment. So that's our coil spring appearance within the small bowel, you know, the valvulae conniventus. That's our coil spring appearance. As the contrast within the intussusception, you know, has, you know, the contrast within it. So it gives you this coil spring appearance that we see. So that's one of the signs. Magnetic resonance imaging can also be used, but of course we know MRI will take time to do. Not every center has MRI, you know, as we know. So, and then MRI will require the child to actually be still. Remember that we are saying this child is, you know, restless, in pains. So it will require sedation and all that, you know. So MRI is hardly used, but it can help to distinguish between the various other structures, which is also what CT can do. So that's it where the arrow is, ileocecal region, you know, T2 weighted, you know, MRI shows us the soft, large soft tissue, shows us the same thing here, coronal view, T2 weighted, the same thing. We're seeing the bowel in bowel appearance, bowel in bowel appearance, bowel in bowel appearance, which will be equivalent to our target sign in ultrasound, you know. CT, the appearance in intussusception on CT is characteristic and depends on the imaging plane, you know, and where along the bowel the images are obtained. Of course, I mention it here so that we don't, you know, we just remember that it can be done. But because of the ionizing radiation exposure and dosage, it won't, you know, CT is not usually applied, you know. So the bowel in bowel appearance can also be seen here on CT. So that's it. That's the intussusception. That's the intussuscipiens, you know, here. And then that's it, you know, for the rectocolic, you know. So that's it, intussuscipiens, intussusception, intussuscipiens. So that's our CT. So the same thing quickly. So look at it, bowel in bowel appearance. So ileocolic, this one, because I have used this, so this one will be, you know, jejunal, you know. So look at it, the bowel loop, bowel in bowel appearance. That's it again, bowel in bowel appearance, axial CT, you know, gastroduodenal, you know, becoming quite low, intussusception. That's it again in the ileocolic region. And then a coronal view, look at, you know, all this in the transverse colon area. So that's it here, you know. So colocolic, the same thing, you know. I think I'll just go due to Michel's diverticulum, look at how big it is. And then, you know, the same thing in the, you know, ileocolic, the ascending colon. So we can see that's the contrast within, and then that's the intussusception going into it. You know, the rectosigmoid, the ileocolic again. So we see this. So the same thing here, the colocolic, that's it, that's the contrast, and then that's the mass here, you know, within. So I will go fast. That's the mass again here. This one now almost gives you the sausage, you know, shape appearance, you know, or the soft tissue mass, you know. So, and then look at multiple dilated bowel loops. air fluid levels. So that is our CT. Then for small bowel, the same thing. Look at the mass here, ileocolic, and then look at it here again, and then multiple dilated small bowel and large bowel loops, So differential diagnosis, these are the differentials. It can be due to an internal hernia, a bowel entering into an internal hernia, can be as a result of volvulus, can just be cyclical vomiting syndrome, appendicitis, can, an appendicular mass, can also give you that appearance. It can be as a result of abdominal trauma that has given rise to what? Mural hematoma. It can be primary bone, bowel tumor, metastasis, others, gallstone ideas. What will be our diagnostic algorithm? Ultrasonography, ultrasonography, ultrasonography. A soft tissue mass, we have mentioned that ultrasound should be the first imaging modality of choice for soft tissue masses. CT, MRI will be the best imaging for soft tissue. But because of the setting, where we are pressed for time, and of course, MRI is not available in every place. So ultrasound. Number two, ultrasound is also the imaging modality of first choice because it will give us an idea of blood flow, which we need in order to proceed for a non-operative reduction of the intussusception. So ultrasound will, with guided hydrostatic reduction, we will do. Ultrasound we can reduce with pneumatic reduction using air or gas, as the case may be. Radiography combined with the ultrasound. So radiography shows us the soft tissue mass. Ultrasound will confirm and then tell us about the blood flow, and then we can do the reduction. And then fluoroscopic diagnosis as well with enema. Enema has to be with water. So complications for intussusception is perforation. So if barium goes into the peritoneal cavity, it worsens. So MRI and CT. So the therapeutic options for intussusception will be non-operative as well as operative reduction. I've mentioned that our surgical colleagues, of course, the surgeons usually will be the ones, or even if it is the A&E, clinician, would have referred the patient to the radiology department for imaging. Imaging confirms intussusception. The surgeons have to be called, the pediatric surgeons have to be called so that they are there when these procedures are, taken. The conditions are mentioned already for non-operative reduction. The patient has to be clinical stable, vital signs. The high index of suspicion that it is intussusception using your sonography as well as your x-rays. The presence of evidence of intussusception by your imaging, no evidence of perforation, no free fluid, no evidence, clinical evidence of perforation, and then we're not seeing free fluid, which will also indicate, or free air in the peritoneal cavity. The aim of enema is to reduce the greatest number of intussusception without producing a perforation. That will be the aim of our, contrast enema. The current standard of treatment for intussusception is image-guided non-operative reduction in a child that is clinically fit for the procedure. Types of non-operative reduction. The three most often used technique, well, I've mentioned already, you can use the contrast medium, and then you can use, saline. So any of them, you do ultrasound guided. You are looking at the mass itself, and then looking at your target sign, pseudo-kidney sign, and then you're using the ultrasound to now look at the saline going through that you have put on a cannula, or a container, put up so that using gravity, it helps, to reduce it, and then you can. And then there is the pneumatic reduction too. Pneumatic reduction, when you use air, you must have the equipment, in order to bring, and ensure that the pressure will be between 60 to 100 millimeters of mercury. So guided saline reduction is one of the best. And then you do all the guided barium, like I said, forgive me for not, doing it well. It's not barium, it should be, water-soluble contrast medium, because we are not sure. That's the equipment that we can use for pneumoreduction, but not every center would have it. But when you do, you have your pressure gauge to be able to gauge the pressure. Of course, because it's an enema, we are putting in the catheter, inflating the balloon to, keep it in place. And then we can now pump the air, to be able to, reduce it. So conditions for operative reduction: when the patient is acutely ill, when one, radiology has verified perforation. If it is a small bowel, so ileal intussusception, it is not, very easy to, take care of it using the enema. Where there is need to re-evaluate and reset the pathologic lead point. So when we think there is a lead point that needs to be resected, then there's no need to do the non-operative, because you eventually need to resect. When the facilities for non-operative reduction are not available. So if we don't have the fluoroscopic machine, if we don't have functional ultrasound machine that can actually show us what we are looking for, then there's no need to say you want to do it blind. It's not possible. That will be malpractice. When the expertise for the non-operative reduction is also lacking, when the radiologist is not confident of doing it and monitoring it, then, it shouldn't be done. The types of operative reduction are these two: laparotomy, and then they can manually milk the intussusception, milk the bowel out of the distal lumen. It is called the milking maneuver. Or you do the laparotomy and then surgically resect the area that has undergone necrosis and then anastomose. In summary, radiology is the cornerstone for the diagnosis and therapy for intussusception. A multidisciplinary approach is advised. The imaging tool utilized depends on the expertise and the imaging equipment present. Of course, we have said the first imaging modality, first line, will be ultrasound, or second line, ultrasound, because we will see the soft tissue component of the mass, we would also evaluate the vascular component. Ultrasound guided non-operative hydrostatic reduction is safe and the best and best in keeping with our ALARA principle, as low as reasonably achievable. So we don't want to expose children, young people, growing people to ionizing radiation. So long as we can use ultrasound, that is what we would apply. And then we'll do either the hydrostatic one or the pneumatic one. Thank you. So we can take questions.
Thank you so much, Dr. Agi. This was a spectacular presentation. A few comments that have been going on in the chat was kind of discussing the choice between pneumatic reduction versus contrast reduction. What are your thoughts as to which is preferable? Assuming you are in a setting where you have both and you could choose, which one do you think we should attempt first? And then there was a comments talking about how in East Africa they may be having higher mortality rates with pneumatic reduction.
Yeah, the literature says that pneumatic reduction usually have slightly more. Of course, we know that we would have to now apply, the gas, or air at a certain pressure. So how do we moderate that? And that, perforations also is more with the pneumatic, So, and that will occur especially in the colon, rectum, rectosigmoid area. That is what is been found. So I think the hydrostatic reduction will be the best option. Hydrostatic reduction using water. Of course, it will be saline, our normal saline. You can use normal saline. That's what we need to use. And then, if need be, if there is the contrast too, we'll be able to use the water-soluble contrast. Now, the other thing too is that with pneumatic reduction, it is said that because it is air, and remember what we mentioned, we said ultrasound does not image, the air as well, sometimes the intussusception may not be as well identified. So, and I think that is what might influence, the amount of pressure people are using in order to reduce it. So the advice would be hydrostatic reduction first. That would be what would be attempted with either our contrast or water or saline.
And then a question from me is, for pneumatic reduction, how do you determine, like, what pressure do you aim for? Does that pressure increase with subsequent reduction attempts? Because you mentioned you do about 3 attempts before you go for surgery. And then does that pressure amount change with the patient age as well?
Well, I'm sorry to disappoint you. I am not sure if, for one, well, the pressure that we are aiming at in order to attain a reduction is usually between 60 to 100 millimeters of mercury. That is what the literature says. But of course, as you know, something that we are doing and viewing it on the screen, yes, it may be possible to increase, the pressure a little. It might, but, that will now be to try to overcome the failure to reduce the intussusception. Of course, after 3 attempts, we should stop and then go for the operative, reduction. So the literature says 60 to 100 millimeters of mercury. So, and that's what, I have. I am not sure if we should, increase it, because like we have said, increasing it actually increases the possibility of what? Perforation, of a complication. So, so I think, that's what, would, influence the decision we take. Of course, if you have done it 3 times at that, between 60 to 100, the maximum should be 100, and then if it fails, we go straight to operative reduction.
Thank you, Zach. Just to kind of clarify, what I mean is, like, say you are doing the first reduction and you gave a range 60 to 100. Are you starting the first reduction attempt at, say, 60, and then second reduction at a higher pressure, or is it the inverse?
No, well, it is this way. You start, of course, from the lower pressure, going up. If it reduces, of course, you don't need to do much anymore. But if it doesn't, you get up to 100 millimeters of mercury. So you can start the first one, you tried maybe up till, who knows, 60. That's 60 to 100. We shouldn't exceed it. If we do up till 100 and it doesn't, we stop. And then we start doing, within that 3 to 5 minutes, when we should, have 3 attempts. So I think we can do that. The reason is, if we start the reduction at, let's say, go up to 60 and we stop, it wouldn't have been a failed procedure at that point in time, because we needed to have at least gotten up to that 100 and see, because if we get up to maybe, who knows, 60, 70, 80, and it reduces, that's fine. But if we get up to 100 and it doesn't reduce, then we can stop and then attempt again. So that's my understanding of it.
Thank you, sir. And then while you're doing this the pneumatic reduction, is this like a real-time reduction? Like, are you able to tell if a true reduction has occurred? Like, how do you know a reduction has occurred? Is it real time?
It's real time. Remember, we are doing 2 things at the same time. One, we are trying to reduce this intussusception, as well as looking at the failure or the success of our procedure on the monitoring screen. So that's what we're doing. So, and then of course, someone is actually also taking still looking at the vital sign of the patient. So we're looking at it on the monitor. And that is why I said the pneumatic reduction, you don't, because it is air, we don't usually see clearly the intussusception within, The only way you know is when you feel the give, the air passes through, because you would have pushed and then you don't feel the mass, you don't see the mass anymore. But if it is the hydrostatic, the fluid, immediately you will see clearly as it passes through. And then remember, we raise up the cannula, we raise it up, in the bowel, so that the pressure comes with the fluid, with the liquid, the contrast, and then enter. But if we choose to do fluoroscopic guided, well, that is it. There will be some radiation exposure to the child, and then you can, still achieve your aim. But hydrostatic reduction is said to be more successful than pneumatic. Hydrostatic reduction has less complications in terms of perforation than pneumatic.
Thank you so much, sir. Do we have any more questions? Feel free to put it in the chat or unmute yourself.
Thank you, Prof. This was a great talk. I hope the trainees have learned a lot. My name is Felix Oyen. I'm a pediatric surgeon from Uganda. I have 2 questions, but before that, I just wanted to add on what you mentioned, that this is a multidisciplinary team approach, that even when you're going to do the non-operative reduction, the theater is ready. Just like Professor has mentioned, if you fail, you're able to roll this child to the OR, or if there's a perforation in the radiology suite, you still have to convert and address the child. So it's
that's contribute along to make those people feel that it's as if this, if we.
Sorry,
Yeah.
someone was unmuted. I've muted them now.
Okay. Yeah. Yeah. So that's really great talk. I enjoyed. However, I have 2 comments or questions I'd like to learn from you, Professor. How was your experience when you started non-operative reduction, especially using pneumatic reduction, especially working with the team of surgeons and the nurses, the entire OR team? What was your journey like to make this feasible, given the challenges we have in most of our settings in LMICs? Getting the team together has not been usually easy. Secondly, what is your experience, if at all? Have you tried using ultrasound guided for the reduction, especially in for centers that may not have a radiologist suite that may be able to do pneumatic reduction or hydrostatic? Thank you.
Okay, thank you. Thank you for the contribution and the question. In my center, we have done 4 hydrostatic reductions. 3 have been successful, 1 failed, and we have never tried the pneumatic. We have never tried the pneumatic reduction. And what we did was ultrasound guided, because at various times, of course, we've had our fluoroscopic machines function intermittently. So, and fortunately, I think so, because we don't want to use ionizing radiation, as the case may be. So, the machines have not been functional. So what we chose to do was do hydrostatic reduction, using saline. With the pediatric surgeon was with us in the ultrasound room in those 4 instances, and they were ready, so our nurse, radiology nurse was also with us, and then we attempted these things. Now, for one of them, we didn't stick to, what the literature says, which is like between 3 to 5 minutes. We actually went beyond that, 7 to 10 minutes actually for the last reduction to try, and then, it reduced. And then we also still checked regarding the vascular flow. So we must also, post-reduction, we must check for vascular flow. We must check for vascular flow. And then the give of the intussusception going back, and then fluid passing through, to the small bowel and all through the ileocecal valve. So we're able to achieve that. But on one occasion we couldn't, and then the child was actually very, very restless. So the surgeon had to go in to do the reduction. So that's the experience we have had. We've never done the pneumatic reduction at all. We've never attempted it.
Thank you, Dr. Agi. We have some questions and comments in the chat. Let me read some of them. From Dr. Norbert says, thanks for the presentation. One of the contraindications for non-operative reduction was perforation. What of when we have bowel gangrene? Can we still do non-operative reduction?
The answer will be no. If we have bowel gangrene, it means that, of course, there would have been what? The venous, compromise, edema, arterial compromise, ischemia, infarction, that's the gangrene. In that setting, ultrasound Doppler would show that there is no flow. So the moment we do, and that is why we said ultrasound is the key. So the moment we identify an intussusception that has no flow in the intussusception, that is bowel gangrene has set in, necrosis has set in. And then we immediately ask that the surgeons, of course, the pediatric surgeons will take over immediately to do, they would remove the dead bowel and then anastomose. So that, so there is, that is a contraindication, either when there is no vascular flow and when we can identify fluid, within the peritoneal cavity, and then evidence of peritonitis. So these three conditions is a no-no, it's a contraindication for us to continue with the reduction. Because if we do, it will just be reducing dead gangrenous bowel back into the abdominal, into the peritoneal cavity, or, and then, there will be, infection and everything that will take place thereafter.
Thank you, sir. Then Dr. Elliot Gerard asks, what is the recurrent, where is recurrence common? Is it manual? I'm guessing this person means pneumatic or hydrostatic reduction versus surgical reduction. And then to add on to that question is, after you reduce these patients, given, the risk of recurrence, how long do you observe the patients before they can go home?
Well, you, number one is that when we do the procedures, like we said, within 3 to 5 minutes, you should have, you will try close to that 3 times, After that, then, of course, you would wait, because there are times when recurrence can occur, If you reduce and it recurs, the literature says you would actually now go for operative, or surgical reduction. So, you would have to wait, observe the patient. In our setting, we usually say they can stay. We are told that these are procedures that you can do, and in 2-3 hours, the patient can go. But for us, we actually kept the patient. The ones we did, we kept them, for longer. We kept them for longer. We kept them for maybe 6, 7, 8 hours. One of them overnight. Because we don't lose anything, rather than the individual going back and then probably a recurrence. So when there is a recurrence, you would have to now opt for an operative, or a surgical reduction. And then you observe the patient, for some hours at least, monitoring the vital signs, listening to the bowel loops, the ultrasound, to be sure that, one, of course, the mass has not returned. 2, the vascular flow is still there. So, like the previous question, peradventure, maybe there was a little flow and you did it, and who knows, the flow disappears. That would be a cause for operative reduction. So you observe the patient for some hours, before the patient is discharged home, but you don't lose much by keeping the patient, maybe for 12 hours, 24 hours or so, observe, and then the patient can, and then while you're doing that, while you're observing, you are monitoring with sonography. You are scanning, you are also doing scanning to see what the imaging looks like. And then you're scanning to also confirm that the Doppler flow is still there, monitoring the vital signs, scanning the patient, sonographic scanning, and then ensuring that blood flow is still there.
Yes, sir. And the earlier question was, where do you have more recurrence? Is it operative management versus non-operative management? Which
non-operative management. Non-operative, that's easy. Non-operative management, because the operative management, the surgeons go in and they take out that segment of bowel and then anastomose. And then remember that we have said that, if there is a leading mass, if there is something that is actually causing it, if a patient has neoplasia, if a patient, has, let's say the hematomas, mural hematoma that has not resolved. In those instances, surgical, management is better. So, surgical, non-operative management has more recurrence than surgical. The surgical management, they will either milk it out, and then, but especially when they are doing the resections, that never comes back. So the recurrence is more with the non-operative management, non-operative reduction.
Thank you, sir. And then the last question here says, various literature suggests varying recommendations about non-operative reduction versus the duration of symptoms, with some studies suggesting hydrostatic reduction in children with up to 72 hours of symptoms. What do you say about the duration of symptoms and non-operative reduction?
Well, the best way to answer it is to say the longer the waiting time before the reduction, the less the success, the longer the time. It is usually said that if a patient presents after 24 hours, that the chances of success is usually less, unlike a few hours, that you can. Of course, we know that if the process has been on for 24 hours or more, you find out that the venous compromise would have occurred, some edema would have taken place. So yes, one has to be wary, in doing the non-operative reduction after, if a patient presents with clinical symptoms that has been there for 24 hours. So we have to be, very careful. Of course, if a scan is done and vascular flow is still there and all, yes, then we can still attempt, But the literature also says the longer the duration, the less likely non-operative reduction should be attempted or will be successful.
Thank you so much, sir. Do we have any more questions before we close the session?
Thank you.
Thank you again. Mine is not a question. I think there was a comment from one of the audience about what Professor just addressed. I hope that answers the question. I know there has been a confusion whether duration of symptoms is an indication for surgery. Professor has clearly addressed that. It clearly shows that it decreases the chance of success for non-operative reduction, but itself is not contraindication. Thank you, Professor. I hope the audience took that comment. And also for the other comment of recurrence, yes, the recurrence, I agree with you, the recurrence for non-operative reduction is about 10%. then surgical reduction less than 1%. The good news is that those who recur present earlier the second time they come, because now they are aware of the symptoms, so they come much quicker and earlier. Thank you. Thank you for the great talk.
Thank you. Thank you.
All right. Thank you all so much for joining us this time. Dr. Agi, thank you so much for taking the time to present. This was a thoroughly well done presentation. I learned a lot, and really very appreciative of the time you spent with us. I will reach out to you regarding sharing your slides, if that's okay with you.
It's okay. It's okay.
Yes, all right. Thank you all so much for joining us. We will close. Oh, sorry. I think we have a comment again. If a surgical recurs, can you do non? Okay. So I guess it's if a patient undergoes surgery for intussusception and it recurs, can you do non-surgical reduction the second time?
Well, I'm not sure, but if it is recurring, again, then I think we would have to look, the surgeons, of course, the team together would have to, consider why is it recurring, what factors are now contributing towards it, before a decision will be made. But it can still be safe to do non-operative reduction first. It will still be safe to do non-operative reduction and watch. But I think the case of an incident that has been operated upon before, now recurring, would need the managing team, that multidisciplinary team, to sit down and reconsider what are the etiologic factors, and then take a decision on it. But of course, a non-surgical reduction can, still be attempted. You don't lose anything by doing that.
Thank you, Dr. Agit. Dr. Oyanya, do you want to add anything to this?
No, I don't. I have nothing to add more. The only thing I also wanted to mention is that for the audience, that the issue non-operative reduction is you're not able to know the lead point. So when the recurrence occurs, most times more than 3 times, 3 or more, most people go surgical. Yes, and in most cases, the advantage of non-surgical reduction are you're able to palpate for a lead point if it is there or not. Of course, remember, the older the child, the more pathological the lead point may be. So, like Professor Claire stated, it's a discussion you have as a team. What is the most likely cause of the recurrency and all those things? Yeah, whether you go non-operative, operative depends on the team really. But most people might go operative if operative comes back.
Okay.
Thank you so much. Very great discussion today. Thank you all for joining us. If you have any more questions that we've not addressed, oh my gosh, okay, we have another one. It says ileoileal versus ileocolic. Which one has the best outcomes in terms of non-operative reduction? Keep the questions coming.
Well, the ileocolic is the one that has the best outcome. The reason is that, remember, we are looking at one loop of bowel entering into another. So the ileum, is entering into the colon, which has a bigger space. So it means that the compression would not be as much as when the ileum, part of the ileum is entering into the ileum. So, in terms of, the outcomes, the ileocolic has the better outcome. Of course, it is the commonest, 75, 85 to 95% or so. More than 85% of intussusceptions occur at the ileocolic, region. So the best outcome is not the same bowel colocolic or ileal. No, the best outcome is ileocolic. You know, a small bowel passing through the large, passing through the ileocecal valve into the colon, and then you can, reduce it back. So that is the best outcome.
Awesome. Thank you so much, sir. All right, I think we will call it a day. And if you have any more questions, you can email us and we'll forward your questions to Dr. Agi. Thank you all for joining us this session, and we look forward to seeing you next month for our next session. We'll send out a communication or email regarding the next session topics and the speaker. Thank you all once again, and have a good night wherever you are, and good afternoon to those on this side.
Yeah. Thank you.
Thank you.
Thank you for having me.
Bye-bye.
Bye.